And we all know this, everyone who's had radiation centers, you go back 20 years, it only took 12 patients on beam to make a profit. Then it moved up to 18 or 15, then 18. Now you need almost 25 patients to support a single LINAC in most settings. And during the same time, we're because of all these cuts and everything happening, so you have these margins that are so tight that you're functioning on. So any of these disruptions are going to close down centers. In terms of the rocker case rate model, it is a great way to protect against this continuing hypofractionation, giving less number of treatments for each disease site because it's a bundled case rate that you're paid for prostate cancer, breast cancer, what have you. But in the meanwhile, some other solutions obviously would be to increase what we can bill. So we had a session on radiopharmaceuticals. We know that the drug pricing on that is pretty much the primary driver, but the procedures and the dosimetry are lagging behind. So potentially more valuations and codes for some of the dosimetry in that space. Adaptive radiation therapy currently is not compensated separately. So new codes for new technologies to help support our centers. And then finally, what CMS did here in the big picture, in the long run, is actually allows for payment stability, because while this chart shows almost a 20% decline in the freestanding centers, during that same 10-year period, hospitals saw a rise of almost 2%. And so having our payments tied to the appropriate hospital payments, which get corrected year after year through their charge masters, is going to be a win for us from a payment stability standpoint. It's just making sure that it's done correctly, and ideally maybe we would advocate for more of our other codes to also go that route.